Welcome to Back to Work, School, and Life, Utility of COVID-19 Testing to Help Communities Restore a Sense of Normality. My name is Patty Love, and I'm your host for this workshop. In this workshop, we will focus on increased testing and how it can help restore communities to a sense of normal or the new normal. I have two terrific speakers with me today. One will give an example of how a university has established a surveillance program for students at the university with our TACPath COVID-19 assay. And the other comes in from the industry perspective with an at-home test in different areas where consumer testing can have impact, such as at home, sporting events, or tourism. By the end of this section, I hope you'll come away with effective strategies for establishing potential testing channels, operational considerations you may encounter, and a couple testing solutions that are available to you from Thermo Fisher Scientific today. I'd like to start by introducing Professor Jared Auclair, who leads the surveillance program for students at Northeastern University. Dr. Auclair is the Associate Dean of Professional Program in the College of Science and Associate Teaching Professor in the Department of Chemistry and Chemical Biology. Professor Auclair also serves as the Technical Supervisor for the Life Science Testing Center at Northeastern University, which is a state and CLIA certified lab. In addition, Professor Auclair is active on the global stage as the Director of the Biopharmaceutical Analysis Laboratory, otherwise known as BATTLE, the Asia Pacific Economic Cooperation Center of Regulatory Excellence in Biotherapeutics and Advanced Therapies, and oversees the International Council for Harmonization Training. These appointments allow Dr. Auclair to collaborate with both academic researchers and industry in the areas of biopharmaceutical development and analysis, as well as international regulators on best practices and new advances in regulatory sciences for drug approvals. Dr. Auclair received his bachelor's degree in biotechnology from WPI and a PhD in biomedical science from the University of Massachusetts Medical. In both instances, Dr. Auclair's research focused on understanding the molecular mechanism of HIV-1. Upon graduating with his PhD, he did a postdoc under Greg Petsko, Dagmar Ringe, and Jeffrey Agar at Brandeis University. Dr. Auclair, I pass it off to you.
Thanks, Patty. It's great to be here to share today with you Northeastern University and Boston's response to COVID-19. I'm the Associate Dean of Professional Programs and Graduate Affairs for the university, but also the Technical Supervisor for our Life Science Testing Center, which is the testing center that I'm really going to focus on today, telling you about and how the university spun that up, essentially in record time, to provide a response to COVID-19. First, though, that I would start with a little bit of background about Northeastern University, in case you don't know Northeastern. The common thing that I hear when I go any place is, "Oh, you work at Northwestern." Like, no, no, Northeastern, not Northwestern, although we love Northwestern too. So Northeastern is a top 50 university. We're an R1 research university. We also have our #1 career services. Interestingly, Northeastern is a university with a global network. So we have regional campuses in Burlington, Mass, Charlotte, North Carolina, London, Nahant, Massachusetts, Portland, Maine, San Francisco, Seattle, Silicon Valley, Toronto, Ontario, and Vancouver, British Columbia, which allows us to really take advantage of the global nature of all of our industries, especially the sciences. Northeastern was founded on a really core concept of experiential education, what we call the Northeastern Co-op. It's a little bit different than what you might normally think about in terms of a co-op. Yes, it's a co-op, a work experience for students, but we have co-op faculty who help students learn soft skills, or what we call power skills, as well as develop relationships with employers so that our students can get jobs and really help the students practice interviews and things of this nature to get a job. We have approximately 5,000 faculty and staff and somewhere around 28,000 students, which I mentioned in the context of, our testing protocol that we've employed. So instead of an an outline of the presentation, what I thought I would give you is a timeline of events. Right, the pandemic started, well, some time ago, but really in Boston, we sort of shut down on March 13th. And the university went fully remote, and everybody had to take their on-ground classes and put them online within several days. And then you can see over time that, there was a testing task force that was instituted in April. We evaluated a number of different testing strategies in May, and then decided on an approach that we were going to follow for the fall semester, fall of 2020, which included the beginning of the setup of the Northeastern Life Science Testing Center. In July, that testing center was Mass State and CLIA licensed, and we took our first samples in August. And I'm going to go through this timeline and break it out in the coming slides so that you can understand the process that we went through to get to where we are today. September was optimization, and October is expansion. So just to recap, in March, the university had to go fully remote. Actually, I can remember it vividly because I was teaching an on-ground class from March 9th through March 12th with international regulators from all over the world, including Africa, Asia, Latin America. They got in just in time to get that in-person training and got out just in time before the airports got harder to travel through because there was less flights. So on March 13th, the COVID-19 pandemic caused Northeastern to transition to fully remote instruction. Within 2 weeks after that, all the students were sent home and all employees were moved to remote. And not exactly all, the majority of, because research continued at the university throughout this time, especially that research related to SARS-CoV-2, and any, obviously, business critical events still continued if you had to be in person. So in 2 days' time, essentially all the on-ground classes were converted to online, which is not a small task. You can imagine trying to take the rest of the semester and put it online in a few days. And it was definitely a challenge. So in April, a sort of reorganization or reopening committee was formed by the university, which consisted largely of the senior leadership. And in that reopening committee, they formed subcommittees. So the idea was for that committee to monitor the current situation in Massachusetts and across the globe, because we have campuses on global networks, and then decide what the course of action was going to be for the university. And out of that, one of the subcommittees that was formed in April was the testing task force. Obviously, that probably gives you a pretty good idea of what the goal of that task force was, to figure out how testing would be part of our reopening strategy, of course. So the testing task force was formed, and I was a member of it, so I have firsthand experience of what happened in those conversations. And we decided on a four-pronged approach to testing, or we were actually tasked with looking at 4 different prongs related to testing. The first being, could we partner with a large diagnostic lab to provide testing for our students? We were monitoring new technologies or new tests that were coming online that we might be able to use, things like next generation sequencing, new antigen or antibody tests coming out. Could we partner with other institutions in the region to sort of combine our forces and test together? Or should we set up our own testing lab? So those were the 4 prongs that we were looking at for most of April into May. So if you first think about partnering with large diagnostic labs, it was a challenge because we had no control over the turnaround time or the variability in turnaround time. So if we sent our samples to a large lab, they gave us the results when they could, and if there were stat samples or samples from a hospital that took priority, ours would get pushed back, right? So we had no control over the turnaround time. We had to pay the Medicare or Medicaid price, and only one test would probably get covered. Then the university would have to pay the full price, which was someplace on the order of $90 to $110 per test per person, or per patient. And at the time, back in April, it was unclear if we'd be able to do repeat testing at all. So those were a couple of things that we considered when we looked at the large diagnostic labs, and we investigated that option pretty thoroughly, just like all of these options. When it comes to monitoring new technologies, usually there wasn't enough validation data available for us to implement that to keep the whole entire university community safe, which, if you remember, was on the order of 33,000 people if everybody came back to campus. There was no emergency use authorization for many of the tests from the U.S. Food and Drug Administration. And the timeline and scalability was unclear, and the supply chain as well was unclear on lots of these technologies. So we didn't know if we would even be able to employ them. We looked at partnering with other institutions. Most of our sister institutions in the Boston area, the large ones, had decided to either use the code, which is part of MIT and Harvard for testing, or they were affiliated with the medical school and had the ability to just go ahead and do their own testing rapidly. So we sort of were stuck between a rock and a hard place, if you will. In Northeastern, we don't have a medical school, so that's one, if you want to call it a disadvantage, you could call it that we might have had. So that option was pretty much eliminated from early on. So lastly, we decided to look at setting up our own testing lab, which we decided we would do in May. Actually, we decided the Friday before Memorial Day weekend, this would be the approach that we should take. So it was named the Life Science Testing Center, or LSTC, as I might call it moving forward. From Memorial Day until June 12th, there was further discussions to make sure that this was the appropriate decision to set up our own testing lab. And on June 12th, we actually began the process of setting up the lab. As part of those conversations, also, we wanted to decide on what kind of tests we wanted to use if we were going to set up our own testing lab. It's an important question. So, of course, we considered both molecular diagnostic or PCR-based tests, as well as serological tests, largely antibody-based tests. Through looking through the literature and information in the public domain, it became clear to us pretty early on that serological tests were not at the sensitivity or specificity that we needed. So we decided to go ahead and create the Life Science Testing Center as a high complexity molecular diagnostic testing lab to start, keeping in mind that we might look at serological testing or other types of tests to bring on board in the future. Like I mentioned, on June 12th, the planning and the work began for the Life Science Testing Center. Northeastern had, in the past, had no clinically certified labs on campus, at least of the high complexity molecular diagnostic tests type. We had one lab that was able to do microscopy clinically, but that was it. So we decided to locate the Life Science Testing Center on our innovation campus in Burlington, Massachusetts. The ICBM is a 14+ acre campus just outside of the city of Boston that the university acquired from the federal government in the 60s. So there's ample parking, and a new building had just been built where the Biopharmaceutical Analysis Laboratory, or BATL, had been set up and instituted, and that's the lab that I run. And I encourage you to take a look at the webpage. There's a whole lot of activity that goes on in BATL that's pretty exciting in the research and education space. So I had 2,600 square feet of unoccupied lab space and 1,300 square feet of protein chemistry lab space that we were going to repurpose into the Life Science Testing Center. So we had the lab space that was already built out and unoccupied, or no equipment for essentially in the space. So we had a blank slate. So we at least had a head start on that. But we had no other infrastructure or anything ready to go. And we have to hire consultants to help us. We decided to hire consultants to help us with setting up our standard operating procedures, or SOPs, and to obtain state and CLIA certification, which was an important part of us setting up the Life Science Testing Center. At the core of everything that we do, or the foundation of everything that we do at the LSTC, and my whole career has been really focused on quality. A lot of my career has been based on biopharmaceutical analysis, and the most important thing to me is quality, quality, quality for patients, and there's no difference in the diagnostic space. So quality and accuracy are at the foundation of everything that we do. We had to determine what type of test we wanted to use, nasopharyngeal, anterior nair, or other. We had to acquire the equipment that we needed. We had to hire and train a staff. We had to select a laboratory information system. We had to design the sample workflow and implement it. We had to secure all the testing supplies that we needed, RNA extraction, PCR reagents, etc. Consumables and disposables, which of course was important for us to gather. And as you might all know, the supply chain for anything related to COVID testing is tight or restricted. So these were all things that we wanted to get ahead of early on. We had to produce validation so that we could be certified at our inspection. So we had basically a long laundry list of things to do in a short amount of time, because obviously we wanted to have this operational for the start of our fall semester. Classes started after the Wednesday after Labor Day, but students started moving in about 10 days before that. So we had to be ready for the end of August. As part of that, we wanted to determine what kind of reagents we were going to use, right? I told you we decided to go with a high complexity molecular diagnostic test or a PCR-based test. And we validated or not validated, but we investigated the different tests were out there and tried to pick the best test for the highest quality or highest specificity and accuracy. Considering a few things as well, right? Because not a ton is known about the virus and the fidelity of the virus, even still, but especially in a high-risk population. In terms of high risk, I'm not talking about of illness or death, but high-risk activities like going to parties or hanging out with your friends, studying and not wearing a mask. So I didn't know, or we weren't sure of what possible mutations might crop up in the viral genome as students recongregated in close proximity to each other. CDC protocol we looked at, which of course has an RNA-seq control for human samples, as well as 2 primers on the N gene, which you can see here is located towards the 3' end of the viral genome. I didn't really find that to be the best test that we could use, so we scoured and looked for other options and came across the Applied Biosystems MagMax viral pathogen nucleic acid isolation kit, as well as the TaqPath COVID-19 combo kit, right? And this is all in June. The thing that really I liked a lot about the TaqPath kit was 2 things, really. One, that it was multiplex, so different fluorescent signal for each primer that was being used. So I could do all one patient in one well and essentially confirm it in triplicate. And that there was primers on the ORF1ab gene, the S gene, and the N gene, giving me a better view of what was happening in the viral genome if there was changes being made. The way I describe it to my friends is basically saying imagine you're on a highway with exit 1 through exit 10. The CDC test is basically exit 10 only, and the test that we decided to use, this TaqPath combo kit from Thermo, is monitoring exit 2, 6, and 10. So it gives us better visibility and confidence in the test result that we're producing. Again, quality, giving us confidence in the quality of the result that we're producing. So, basically we enacted this simple sample workflow, the one recommended from Thermo Fisher. Sample collection, we decided to go with anterior nair swabbing. Nasopharyngeal would not result in compliance from our student population likely, but we figured AN swabbing was the best case scenario. Saliva had issues and wasn't at the place where we were ready to consider it. Obviously, we purchased a number of liquid handler robots to help with the pipetting so that I didn't have to have people pipetting thousands and thousands of times in a day. We went with the Applied Biosystems 7500 FACS-Dx real-time PCR machine because it's clinically certified or has clinical use and practices, so it can be IQOQ certified. And then, of course, one of the great selling points is the interpretive software for COVID-19, because that was our main focus of the lab. In the future, we think the Life Science Testing Center won't only be doing COVID testing. We're hoping to be able to implement a flu A, flu B test, perhaps a multiplex with flu B and COVID, as well as other diagnostic tests that are molecular based, but also looking at licenses for antibodies and other things that we can provide, as well as an opportunity to do both clinical research and diagnostic research and other clinical research. So from June 12th, essentially, to July 31st, in 6 weeks, we set up the lab. We hired an initial staff of about 12 people. We validated all of our instruments and workflows and had our CLIA inspection or Mass State License inspection on July 31st. So that's 6 weeks in total from mustard seed, if you will, to complete operating lab was past inspection and ready to operate as of noon on July 31st. And the consultants we used, this was the fastest they've ever done it in the 30 years they've been in business. Of course, I would, if you're a baseball fan and remember the home run derby of Sammy Sosa and Mark McGwire, the asterisks, I would put an asterisk here on the 6 weeks, of course, because it's COVID and it was prioritized by the state for inspection, obviously. So then we had to set up the testing sites. So we set up a couple of testing sites on the Boston campus. One of them we call the Cabot Testing Center. This is for routine surveillance testing. We set this collection site up in 2 weeks with a throughput of, or has the capacity of a throughput of 8,600 samples per 12-hour day. The maximum that we've seen go through there to date is 7,500 tests. And for whatever reason, Monday seems to be the most popular day to have a test. Then we set up another testing center, the Huntington Testing Center, for symptomatic testing, and we set that up in 3 weeks. And then our first samples arrived in the lab on August 17th. We received 1,500 samples that day at 1 p.m. And then we were only operating from 7 to 9 p.m. So like I mentioned, we're using anterior nair swabs, and they're coming to us dry where we add viral transport media. They're transported to us, the LSTC, by a medical courier from Boston. Every test is ordered by a physician. Students are tested when they first return to campus on a 3-day cycle, so day 1, day 3, and day 5, before they can enter a class room, or do anything on campus. After that initial set of tests, students are tested every 3 days. Employees who are on campus 5 days a week are tested twice a week. We also test all NU community members. That includes employees, students, and contractors. So with the 3-day testing cycle, again, one of the reasons we went with anterior nair swabbing is to ensure people complied with the testing. So if you look at the testing center by the numbers in operation and where we've come from that August 17th date till basically today, right now we have 8 biological safety cabinets in operation. We have 7 liquid handlers in operation, 9 qPCR machines running, approximately 7,500 clinical testing staff. We have additional lab support. We have 1 supply chain manager. And actually the lab support was added after the technical staff as needs arose. So we have a supply chain manager to mitigate against supply chain risk, like I mentioned. So some things that are really hard for us to get are pipette tips that have a filter, because the filter itself is apparently on back order. So that's something hard for us to get. Even biological safety cabinets are like getting toilet paper at the beginning of the pandemic, very hard to do. So we have a supply chain manager ensuring that we have continuity and resilience in the supply chain. Quality is the most important thing to me, so we have a QA QC manager to help ensure that we're maintaining quality and following our SOPs and all of those great things. We have a lab information system manager to help us with the lab information system and processing, making sure that the results are released and processed properly and understanding how to use that system to best benefit our community or our patients. And we have an ITS manager for the lab to help with lab instrumentation and other things. We realized really early on that our goal was to process 5,000 samples a day. To be able to do that realistically, we had to move from a 12 or 14-hour day to a 24-hour operation 7 days a week, which is where we're at today. So, we started on August 17th with around 1,300 tests that day. I mean, ideally, I would have scaled up from July 31st to the end of August, taking several hundred tests the first week, 1,000 the second, to 2,500 the third, and so forth. We were surprised by the number of people who wanted to be tested. Our forecast didn't predict that. We predicted 100 or so folks on campus those first few weeks that would be tested. in reality, people are very interested in being tested and making sure that they're COVID or SARS-CoV-2 negative. So we weren't able to scale up in that fashion. But what we were able to do is process those 1,300 tests per day for the first several weeks. And then we are also using the Broad Institute as a good business practice to have resiliency in our testing regime. So if something happens to them or the LSTC, we have backup. So for a weekend, we sent almost all of our samples to the Broad so that the life science testing centers could get her feet under her. That was the weekend of August 24th or around there. And then started operating again on that Monday, taking about 1,500 samples a day and scaling it up to 2,500. And then by the beginning of September, we're able to process 5,000 tests per day. And we've been doing 5,000 or between 4,500 and 5,000 tests per day for the last days. Actually, we process all of our tests on the weekends now. And we send less than 40% of our tests to the Broad. This week, we're doing a capacity experiment to see how many tests we can actually process in a 24-hour period. And this is the week of October 5th. And we were able to process 6,500 tests in a 24-hour period. And then hopefully moving towards October, we're going to be able to process even more tests in a 24-hour period on the order of 13,000 to 16,000 tests per 24 hours. We also decided, because we're doing our own testing, it would be cool if we could use it for research opportunities. So we do have IRB approval for a research repository and registry, so that we can have a better understanding of COVID-19 and preventing the next pandemic, and validating new diagnostics coming out of labs and other places, and partnering really to do exactly that, understand COVID-19 and preventing the next pandemic. So we are also able to do research. That's the beauty of working in an academic institution and having a testing center here. And then, like I mentioned, in October, we want to get to about 13,000 to 16,000 samples per day. So, at noon on October 8th or so, we were given our temporary certificate of occupancy for a 3,250 square foot lab expansion. That lab expansion will include 8 additional biological safety cabinets, 6 additional liquid handlers, and 6 additional qPCR machines. We had previously hired enough staff to train in the old space so that we could expand into the new space and be ready to go, and are considering currently what might be available for us to test outside of the Northeastern community, including local communities around the university or other universities that we might be able to help with this increased capacity, as well as if there's a need from the government at some point. So in our 4-pronged strategy, it's still right. Like, we plan for the fall semester, but what's going to happen in the spring? And we're trying to figure that out now. I mean, we took partner with large diagnostic labs sort of off the list. We won't pursue that as an option. We are still monitoring new technologies as they come in, including still next generation sequencing and point of care tests. Your sort of paper-based tests and rapid response tests. At the very least, to reduce the number of PCR-based tests that we have to do, sort of to do a 2-prong approach, not replacing PCR, but helping with that. We're still looking at how we might partner with other institutions, more from the how we can help them as opposed to them helping us standpoint, and other that we might help test for. We want to reduce the number of PCR tests we're doing, so we're looking at other options like pooling serological tests plus PCR, like I just mentioned, and are exploring those to see if there's any added value. We are looking at, like I mentioned, the flu A, flu B COVID combo test, which we would deploy for symptomatic patients. As the flu season sort of kicks up and the winter comes upon us in New England, we're expecting more people to be inside and people to get sick, so we want to be able to perform at least the flu and COVID tests as they're sick. And of course, we're looking at other opportunities the lab could provide for testing. So with that, it was great to tell you about our journey towards reopening the campus this fall and beyond, and the strategies that Northeastern took to do that. I'm really proud of the fact that the senior leadership has allowed us to put quality at the forefront of everything that we do. providing quality tests and keeping the university safe. And over the last 7 days, in this week of October 5th, I'm happy to say that our infectivity rate on campus is less than 0.02%, which is really exciting. And we do have our own contact tracing as well that's allowing us to keep control of campus. So with that, I thank you for your time.
Thank you, Dr. Auclair. It's such an inspirational story to hear how this program was pulled together from concept back in April and how it's developed into the strategy it is today to support the health of the university community. Now, let's pivot over to the industry side and hear how Everlywell's home collection enables a healthy return to office. We are excited to have Dr. Frank Aung here today. Dr. Aung is a Chief Medical and Scientific Officer at Everlywell, the digital health company poised to disrupt the lab testing industry by providing consumers with an at-home testing kit that includes insightful, easy-to-understand results. Dr. Aung leads the company's medical affairs, including clinical laboratory operations, research, and clinical development, including new test development. Prior to joining Everlywell, Dr. Aung held leadership positions at Guardant Health, Roche Diagnostics, and Illumina, and served as a faculty member and researcher at Cedars-Sinai Medical Center, where he received research grants from the NIH. He earned his medical degree from the Keck School of Medicine at the University of Southern California and holds graduate certificates in clinical and translational investigation, biodesign, and medical device innovation and clinical trial administration from Stanford University, UCLA, and University of California, San Diego. He served his residency in the Department of Family Medicine at UCLA's Geffen School of Medicine, and he resides today in Austin, Texas. Thanks for joining us today, Dr. Aung. I'll let you take it from here.
Thank you, Patty. Good afternoon, everybody, and welcome to the session on Back to Work, School, and Life, Utility of COVID-19 Testing to Help Communities Restore. In this session, we're going to briefly review the background of COVID-19, the state of COVID-19 testing, as well as how to develop a program to get communities back on track. The situation is that we have the COVID-19 emergency being quite fluid in nature, so please do inform or refer to information provided by your federal CDC or public health officials and government authorities for continued guidance. And another point of disclaimer, for the Everlywell COVID-19 test home collection kit, it is authorized by the FDA under a EUA. It has not been FDA cleared or approved. This home collection kit has been authorized only for the home collection and maintenance of nasal swab specimens as an aid in detection of nucleic acid from SARS-CoV-2 and not for any other viruses or pathogens. My name is Dr. Frank Aung. I am the Chief Medical and Scientific Officer of Everlywell. And at Everlywell, we empower people and organizations with at-home healthcare that is comprehensive, trusted, and actionable. So briefly on COVID-19, as all of you know, the cases continue to rise across the United States. As of end of September, we are at a total case of over 7 million, with total deaths of over 200,000. And in just the last week of September, we logged over 300,000 cases. The numbers continue to rise in this first week of October. Briefly, the COVID-19 SARS-CoV-2 virus can take anywhere from 2 to 14 days for symptoms to appear after infection. And as all of you probably know, a good proportion of individuals who are infected are in fact asymptomatic carriers, not exhibiting any signs of symptoms such as cough or runny nose. We are not sure at this point whether a history of SARS-CoV-2 guarantees or does not guarantee immunity from future infection. And just a few days ago, we had confirmation from the CDC with regards to the air droplet and airborne transmission of the virus. Obviously, the most important risk factor for infection is close contact with someone that is infected. In the times of COVID, businesses are charged with protecting their participants. In the latest review from the American Journal of Public Health, 3/4 of American workers are at risk for increased exposure by working on site or are experiencing job uncertainty because of workplace closure. Almost 50% of employers say that they have employees or participants that are afraid to return to work. And the estimated cost of employee benefits for workers who are absent from work total $23 billion. You've probably seen or heard in the media about the need for organizations to implement testing strategies as they consider safe methods for expanding on-site opportunities. One very obvious group is the employers, and I'll share more about safe back-to-office methods for employers in a bit. The need for increased COVID testing at schools is becoming more obvious, especially given the fact that the CDC reported just in the few weeks in late August that the increase in the persons aged 18 to 22 for COVID cases was almost 50 to 55%. This aligns very much with the timeframe when many went back to school. Additionally, it was confirmed by CDC that in-flight transmission of coronavirus is possible, and so we've seen airlines offering testing for COVID-19 before flights, especially for international travel. To design a program that works, it is different for each organization and what that looks like. First, we need to understand the government guidelines from the federal level from CDC and HSS to state and local public health officials and authorities. Next, we need to look at what type of testing and how much of testing is necessary for each group or organization. And the type of testing ranges from PCR testing to antibody serology testing, direct or rapid antigen testing, or a combination of all three. We also need to look at the support that the organization needs, whether they have in-house medical staff or a fully outsourced model, and the risk tolerance level for each organization. And this really depends on each organization's and employee composition, the commute behavior, location and structure of the actual office space, and the health and the demographics of your participants and employees. The COVID-19 testing goals ranges from the health and safety of employees and customers first, to a comprehensive solution, and finally to efficiently return to the office space. In terms of the primary goal for employees and customers' health, there needs to be a triage for those who need immediate care, and then remote management of those with mild to moderate symptoms with COVID positive cases through the quarantine period. In terms of the comprehensive solution, it is a choice between ongoing surveillance and screening every few weeks, to a protocol that is single-use testing and screening, and most importantly, the data collection, reporting to state and local authorities, as well as contact tracing from the positive cases that result from the testing. Finally, in terms of efficiently returning to office, we need to have a clinical protocol developed with regards to those that have previously tested positive and recovered, those that are currently infectious, as well as the ones that may have already been infected and may have immunity conferred upon them. Next, I want to talk about the Everlywell digital health platform and how that works with COVID-19 testing. So first of all, the Everlywell digital health platform helps organizations facilitate at-home healthcare with a seamless end-to-end solution. It is a comprehensive end-to-end solution that we offer, from handling the test distribution, the actual kit, to monitoring the testing status at every step along the way, and finally, with regards to evaluating and displaying, reviewing results. We work with the highest quality testing labs that are CLIA certified and CAP accredited, and Everlywell was the first digital health company to receive an at-home COVID-19 EUA that was not tied to a specific lab or a specific manufacturer of the test. The results from our tests are actionable and they're accurate. It is on our digital platform that empowers the participants to take action on their health while giving the organizations access to keep those testing reports. Even though not related to COVID-19, I want to point out two examples, one of which was with a health plan, a major health plan, with regards to diabetes testing and monitoring, and where we noticed, and the health plan noticed, that testing compliance rates increased by 48% year over year from non-compliant members. Another example was for colorectal screening, and then with another major health plan where positive FIT or fecal immunochemical test results were twice more likely, the members that received those positive results were twice more likely to see a doctor versus the previous comparator. And this is a result of, again, the platform being easy to use for both the participants and for organizations. Participants can easily order the tests through our webpage. They have a simple instruction that make at-home collection easy, and they view and keep their results and data and can refer to that at any time. For the organizations, the tests are shipped directly to the participant's home. Everlywell Lens enables viewing of each participant's test status, and there are alerts of abnormal results that are delivered immediately. In terms of the workflow, the shipment and the purchase goes out, the participant registers. Once that happens, a third-party physician network authorizes that requisition. The sample is collected at home, sent to the partner labs, and processed. The results are then reviewed by the physician, and then finally pushed back to the user or the consumer through a viewable and is viewable by organization and participants. This platform makes it possible for organizations to improve business continuity and keep participants safe during COVID-19. An example of how our digital health platform has helped in the time of COVID-19 is the use case for the city of LA. There were 160 sites across the city of LA that participated in this initiative, and over 70,000 COVID-19 test home collection kits were distributed. And you can see here from the Chief Medical Officer for the LA Jewish Home that the best summary, and this is quote, the best summary of the Everlywell process is this: your work is helping to save lives during this unprecedented pandemic. Through Everlywell, we have been able to test both asymptomatic residents and staff, and we've been able to effectively stop the spread of the virus across 1,600 staff and 1,100 residents by catching it early. So at Everlywell, we created a HIPAA and Medicare compliant infrastructure in a complex lab testing industry. We've worked with, and we are continuing to work with, CLIA Certified and CAP accredited lab network, including our own CAP accredited lab. We have a network of COVID-19 testing labs, and we also have a partnership with Thermo Fisher as well. This extensive quality assurance and monitoring and testing is very important for the accuracy of the results and fast turnaround time for the patients. The process, again, is physician reviewed and customer supported. The diagnostic panels include the physician consults and prescription, and all the results discussions are handled with registered healthcare professionals. We also have an in-house clinical team that supports questions, and this demonstrates a high net promoter score, which is customer satisfaction in a nutshell. You can think of Everlywell as the Lyft or Uber, connecting consumers, employees, students, athletes, etc., to laboratory network for COVID-19 testing. So we help by focusing on what matters most, and that's sample processing. We also have a very transparent flat fee per sample, no hassle with insurance. We manage the supply and demand and provide the end user or consumer with the kits and components for collection. Electronic orders through the laboratory network makes the receiving and accessioning seamless. Results are reported electronically, and we handle all user-facing results, content, and questions. To summarize, Everlywell has low error rates and high customer satisfaction. The issue rates are under 5%, and again, the net promoter score is over 70. We have a dedicated team ready to resolve issues that require follow-up, and that's missing information and correct names, etc. The quantity not sufficient remark with regards to kits are then automatically sent a replacement kit for the end users. Our lab API and portal allows for sample issues to be tracked, and so there's no need for a manual handoff. We have unique kit ID barcode that links the electronic lab order, ensuring results are tied to the correct order. And we have patient identifiers that are verified upon receipt for the samples, ensuring that the right samples are matched with the right results. Thank you for your time, and I'm happy to take any questions at this time.
Thank you, Dr. Aung, for sharing the Everly Well story. From hearing about university testing and employer testing today, I hope our participants come away with some effective strategies for establishing testings to help your communities come back to school, back to work, back to life. And know that Thermo Fisher is a partner to you in finding the right testing solutions to help you and your communities reestablish that sense of normality. Thank you for joining us today.